You're listening to ABC Radio Melbourne.
I am joined now by an orthopaedic surgeon, which is the perfect segue from international people of mystery to people who need a little bit of renovation, whether you are an overworked parent or a spy on a geopolitical scale. And the orthopaedic surgeon is Justin Hunt from Epworth, and he joins me now. Welcome, Justin.
Thanks very much, David.
Your favourite Bond movie?
Oh, Goldfinger.
Goldfinger, yeah, pretty good, isn't it? In fact, did you want to? I'd imagine that. Did you want to grow up and be a surgeon, or was there other careers that you dabbled with?
Yeah, I think the lifespan of 007's too short. And yeah, I didn't really understand what orthopaedics was until a friend of mine broke their arm, primary school, and then forgot about it. And then there was a man in a three-piece corduroy suit playing a clarinet in a medical school lecture, drawing three-dimensional spine diagrams on an acetate overhead display, as they did in the old days.
Yeah, they did.
And that was it.
So you were hooked?
I didn't want to emulate him, but I thought this is interesting.
It is. Have you? The one thing you would need to be as a surgeon, I imagine, is dexterous. It's high pressure, and we'll talk about the area of hip replacements very soon. But I'm just interested in your practice. Have you always been super handy? Can you sort of fix a bike tyre in the dark?
Possibly, but I find just getting the tyre off the wheel sometimes a challenge. But from the point of view of dexterous things, yeah, you tend to gravitate towards things, carpentry, physical things, and yeah, I guess traditionally a lot of that's been male sort of role model type thing, but there's more women coming into orthopaedic surgery now. But it's just an affinity with people, technology, and being able to do something that's effective.
Could you help me understand the range of that word orthopaedic? Obviously, it takes in hips. What else is within your sort of portfolio of theatre work?
Yeah, so the word really originates from paediatrics and bone straightening, but it then grew to encompass what is paediatric fractures, adult fractures, and then elective orthopaedic surgery, which is now really a large proportion of what orthopaedic surgery is about. There's the trauma, and then there's the elective, which is really a lot of arthritis. And the spectrum of disorders an orthopaedic surgeon is taught in is from paediatric orthopaedics through all the different specialties, whether it be hip surgery, knee surgery, foot and ankle, shoulder, spinal, and then also the world of trauma. So when you come out as an orthopaedic surgeon, you've kind of gone through the mill. You've learnt all the different aspects of orthopaedic surgery.
From top to toe.
Literally, apart from the skull.
Yes.
And then you can make your final decision about where you want to end up.
So the hip is where we're going. That's your specialty, the hip.
Yeah.
And this conversation was inspired by a dear friend, Sally, if you're listening, Sally, who was in acute pain for over a year, 2 years, just doing simple things like walking and bending. Her life was really very limited. She's only in her mid-50s, and it was quite distressing to see, knowing just how physical with yoga and cycling Sally is and was. Then she had a hip replacement, and the transformation is palpable. Tell me a little bit about hip replacement as an operation. Has it had major developments in the last few years?
Yeah, over time, the operation was introduced about 50 years ago, and that was a very different world to the one we currently live in. And over that 50 years, there has been an evolution of what the hip replacement is, but there's a lot of similarities to the way it was 50 years ago. But when you mentioned before the titanium hip, and often there are different types of bearings. The technology has improved so that the longevity of hip replacement's improved, and that's important because people like your friend Sally, who are younger than we would have previously wanted to perform an operation on, the threshold's gone down a little bit, and that's one of the reasons why the number of hip replacements that are being done has gone up, because the spectrum of people requiring them has increased, but also that spectrum at the other end is people living longer. And so, for example, a 96-year-old who comes and sees me, who's really quite good, could go another 10 years, of having good quality of life at home. It's not known how long she'll be around. But if she's from home and she's got an arthritic hip and she can't walk, she will be very keen to have an operation. If her family and she comes along to see me, we'll have a discussion. And if she's medically fit enough, then that's something that could be considered.
If you have got concerns or questions about hip replacement, are you going through pain for whatever reason with the likes of osteoarthritis or rheumatoid arthritis, or are you on that sort of threshold, that quandary, then possibly Justin could help you here. I'm talking with Mr. Justin Hunt. You guys don't get doctors, do you, being surgeons? Mr. Justin Hunt from Epworth, who's an orthopaedic surgeon. The time is bang on 2:30. You're with David Astle here on Afternoons. We've got quite a few texters already coming in, and that's on 0437 774 774. And one of them says that, from Anonymous, I'm going to have to say, Justin, that Mr. Hunt is operating on me to replace my right hip on the 13th of March. So that's only in 2 weeks. Looking forward to getting my mobility back. It's great to hear. So why titanium, Justin?
Titanium is commonly used because it has a similar elastic flexibility to bone. So if you're looking for the perfect metal that you might be able to introduce into the skeleton, that's one. The other thing, it doesn't rust. Mm-hmm. It forms an oxide layer, so there's no problem with a rusty titanium hip that decays over time. And often the bearing surface in the hip is different from the thing that attaches to the bone. So with a conventional hip, you have a socket that attaches up onto the bone. The bone usually grows onto that. And then on the bottom side, called the stem that fits inside the femur, you'll have either a cemented component, which is usually stainless steel, mm-hmm. or a titanium one. And the bone grows onto the titanium, whereas the stainless steel cement is used. And they're the two main types of component on the bottom part, but usually it's cementless on the top, made of titanium.
So I have this rough image in my head of ball and socket, which is the classic acetabulum makeup. The ball is the titanium component, or is that still other compounds, or is porcelain is still used at all, or not?
So the ball can be a number of different types of material, but it's usually metal or ceramic in these days.
Ceramic, right?
And it's usually not titanium because titanium oxide rubs off very easily, and that produces a black staining. So the old titanium hips causes staining of the tissue. It was all black inside. But cobalt chrome bearing on another bearing, which is usually polyethylene, or a ceramic head bearing on polyethylene, or two ceramic surfaces. So there's usually 4 parts to a hip. There's the socket, which is the metal bit.
Yep.
Then there's a liner that fits inside the metal bit, which could be plastic or ceramic. And then there's the head, which bears up against that. And then there's the stem. So there's really 4 parts.
My apologies to people who are feeling a little squeamish just driving along the Monash at the moment, thinking, "Oh, please, enough with the socket and the ceramics." So let's move it on away from the anatomy, because that could actually be turning a few stomachs. Well, maybe having a late lunch here, Justin. What about the? Have you seen? Have you ever? Seen someone on the table that aside from being a patient? Has that ever happened to you?
Yeah, that does happen from time to time because, in a community, for example, like a medical hospital environment where somebody might come in through the emergency department or somebody might come in electively, you might see that person in the hospital, or you might end up being involved in their care. That's not a very common phenomenon, but it has happened to me on several occasions. But it's always good to be one step removed, ideally, from treating somebody.
We've got some lovely texts coming through, including from Sally on 0437 774 774. You're going to blush here, Justin. My husband, Lance, had his hip replaced the week before Christmas. He had been in pain for over 12 months and not able to ride his bike. I'm happy to say he is a new man and last week went for his first bike ride again. Justin is a miracle worker. That's from Sally. No, I don't think my friend Sally, but another Sally. I had a hip replacement in 1985 that is still doing well. Margie's asked about knees. If we got a chance, Margie, we'll get to knees because a lot of people do have issues with knee replacements. I'm keen to know though, Justin, are you also that person who writes the cover note to get people through the airport X-rays? Are you the one to see for that?
Well, yeah, although it doesn't really help. It sounds good on paper, but in reality, they'll be very thorough. But what I did want to make a point. One of the wonderful things about being involved in the surgery, which I'm not necessarily privy to, is I see people who come to see me and they explain their problems they're having, and then they'll, after discussion, often decide if they are appropriate for a hip replacement operation to go ahead. And I must say I really take my hat off people who come in for an operation because it's quite overwhelming.
It's terrifying.
But everyone turns up.
Yeah.
And the reason they turn up is because there's a problem that needs to be fixed. And they can usually control their anxiety and say, okay, I've got to go through this to get the benefit. And then they come back afterwards. And with hip replacement, it's really the number one procedure for good outcome. So in itself, inherently, it's just a wonderful operation. It's probably better than any other operation for restoring quality of life across the board. So seeing somebody come back and they give me a snapshot of their life, it's very rewarding for me, and also it's usually been a very positive experience for them. But what I don't get to see is, like your friend Sally, the day-to-day, seeing Sally walk down the street or sit in a chair or get up and be pain-free, and that transformation I saw recently with a relative of mine who did have a hip replacement. And I was quite taken by all the things that people do very early after hip replacement.
She said that she felt better immediately after she surfaced from anaesthesia. And Sally, I should say, also did a 16-kilometre hike with the party I was in up at Mount Buller on the weekend. This is a woman who could hardly walk down to the corner shop without anguish on her face. So those outcomes are, in your hands, Justin. Talking here with Mr. Justin Hunt, who is an orthopaedic surgeon. I'm only saying Mr. to rub it in. I can't believe you guys don't get doctors. Justin Hunt, orthopaedic surgeon from Epworth. Many questions coming through on 1300 222 774. If you've got a question that you'd like to ask an orthopaedic surgeon about hips in particular, or these sorts of replacement operations, joined here by Michael from Crib Point. Welcome, Michael.
G'day, presenter and Justin. How are you?
G'day, David's the presenter and Justin is the surgeon. How can we help you?
Look, I was diagnosed with a bit of arthritis when I was 34 as a knee replacement.
Yeah.
I find my hips really degenerating as well. Now, being an avid runner, I just really sort of hesitant in actually getting replacements done, and sort of curious as to how far off is the technology for actually having kind of liquid injections to replace meniscus and cartilage kind of things.
Thanks for the question, because it is very relevant. A lot of young people have significant hip and knee arthritis who love to run. The liquid injections, there are some that are currently available, but they're not really transforming the internal structure of the knee. They're more to change the symptoms that you have. But a lot of younger people may benefit from injections in the short term, which might stave off the inevitable joint replacement. You shouldn't really run with a knee replacement or a hip replacement. I should make that clear, because that will accelerate the wear. And we know that younger people wear out their joint replacements quicker than older people do, basically because they're more active. Coming back to your question about the injectable, stem cell research is going on at the present time. There's a lot of interest in it, and there's some studies going on in Melbourne looking at arthritic knees and use of stem cells. And the jury's still out as to whether that is going to be viable in terms of improving symptoms. But again, they're more at symptomatic improvement, not necessarily restoration of cartilage inside a joint. So I think we're still some way off that.
Thanks, Michael. Thanks for your question. We've got lots of callers on the board here, including someone asking about, Tim from Blackburn has asked via text, can you ask your guest, Justin, if it's possible to repair the gap between the ball and the socket rather than replace a shim replacement? Is that possible to repair the gap?
That was tried very early on,
Yep.
And a little metal spacer was put between the two. It didn't work. So, look, there are ideas of resurfacing joints, and metal-on-metal resurfacing came in the late 90s in the form of Birmingham hip replacement. And metal-on-metal bearings were thought to be the answer to a lot of problems in hip replacements. But unfortunately, the chromium and cobalt wear problems resulted in those type of things being taken off the market. So they're not currently available.
The time is coming up to 20 to 3. You're with David Astle here, filling in for Rochelle for afternoons. And Justin Hunt is the gentleman who's been answering all your questions, and he is an orthopaedic surgeon at Epworth. Now, I'm going to go over to Rani here in Vermont because she's actually looking at knees, and quite a few different questions have come in via text about knees. So hopefully we can answer a few questions. Rani, welcome.
Oh, good afternoon to you and to your guest, Dr. Hunt.
Thank you.
No, it's Mr. Hunt, I've got to clarify.
Oh, yes,
No,
sorry.
I'm joking. No, surgeons
Mr.
don't get doctor.
Hunt,
It's a historical
yes. Thank
thing.
you very much for your time.
No, all right, sorry.
A question for me is that I have been asked to do a knee replacement, and what happens is that early in the morning, behind my knee, I get a lot of pain, and that pain starts in the early morning, and it stays almost for some time. And then when I get up from my bed and I'm walking around, the pain is gone. So I really don't know. I have seen 2-3 doctors. They're asking me to do a knee replacement. I'm pretty good with walking. I can walk up to a kilometer. So I'm just wondering, with this sort of pain, is there any other treatment, or do I have to do a knee replacement?
The answer is no. You never have to have an operation. And while your story in terms of your morning stiffness and difficulty in the morning is really common with a worn-out joint. So often people will have difficulty sometimes sleeping at night, but also getting up, literally feeling 100 years old, and then half an hour or so later, people can then gradually improve, and they can be quite good. Other people have the reverse problem where they're fine in the morning and have difficulty at night. So it's almost unique to the individual, but if you can walk a kilometre and you can manage the pain, and sometimes more exercise helps knees. Knees are quite different to hips. Hips generally, it's all downhill with hips in my experience, but the slope itself can be very slow over many years or very rapid over a couple of months. Knees are very different beasts, where they can change from seasons. They can change because you walk down to the corner shop a bit more often, and that can improve the symptoms. Or they can change with small changes in daily habits or weight. So that's where, with a knee in particular, staving off the operation for as long as possible by trying many different things, and even a simple knee brace is something that you could try, because ultimately you avoid the risk of having an operation if you avoid having the operation.
Wonderful, Rani. Look, we're going to have to move on because we've got many other callers. Thanks so much for yours. I really appreciate it, and all the best with that nighttime pain. It sounds like you're going through a fair bit of anguish there. All those callers makes me think that we need to get you back, Justin. I've got maybe one more. It sounds a good one. It's Alex is calling in. Welcome, Alex. Can you hear me? Beg your pardon, Alex. Can you hear me?
Yes, I can.
Hello. You got a question here for Justin?
Yes, I do. Justin, thanks for the information. I'm just interested, as a result of the hip operation, I've experienced that one leg is shorter than the other.
You're not pulling ours, are you, Alex?
Beg your pardon?
You're not pulling ours? No, I'm sorry. I'm being facetious. So, look, is there something that Alex can do just to anticipate your question here about that?
Yeah, so that is a common side effect of an operation, and it's taught amongst orthopaedic surgeons that stability of the hip is the number one thing. Sometimes the leg's made longer to offset a problem with the hip potentially popping out of joint, because that's extremely disabling. Other times the stem of the hip replacement can subside a little bit after the operation, and sometimes it's a technical issue with getting the right length, knowing where it started and where it stops. But there's quite a lot of planning available now to limit that risk. But one of the primary goals of an operation on the hip is to make the leg length equal. But and there's an algorithm. If it's a centimetre or so, a heel raise in a shoe. If it's more than that, then it might need to be a different sort of shoe modification. And occasionally there's very big differences that need to be accommodated, in which case very occasionally further surgical intervention might be indicated to restore the biomechanics of how the hip works, because if the muscles are very short, sometimes there's weakness associated with that. It's mainly shortening rather than lengthening. So I hope that gives you a snapshot, Alex, into the world of leg length and hip replacement.
I hope so, Lex.
I appreciate that.
Yeah.
So I would need to go back and see what can be done.
Well, measure the difference is what I'm thinking, and if it's a marginal one, then possibly orthopaedic shoes can come to the rescue. And if it's longer, just to reading Alex's response there, then possibly there is at the very outer, sort of outside, a chance to go in and to readjust by surgery. But it seems like that's your last option.
Yeah.
Yeah.
Yep.
Thanks,
Appreciate
Alex.
your information.
No
Thank
troubles.
you.
All the best. All the best. Many texts coming through, including love my replacement hip and knee. The knee was easier than the hip, but both operations were awesome. No more pain. The secret, in my opinion, is a top surgeon and commitment to rehab. Very much the case, because that's the thing. We shouldn't be channeling everyone into the operating theatre. These are options only, but when it comes to acute pain, it seems that, particularly with the hip, there is relief at hand. And this is another Sally, would you believe? The third Sally that has come up in the hour. It seems that they are prone to hip problems. David, not all hip replacements are successful. In 2013, admitted for replacement, woke up in intensive care, found out the surgeon had fractured my acetabulum before putting in prosthetic, and I'm still suffering long-term and chronic problems. Justin, I suppose some things can go wrong and not work out.
That's correct. And the complications associated with this operation are significant, or can be significant, and are well-known, well-documented. And the risk associated with doing these operations are quite a few. And that's where a detailed discussion with the surgeon who's doing the operation about what those risks might be, and also the strategies they use to minimise the risk, because understanding those risks prior to surgery is very important. And as Sally has clearly and very vividly pointed out, if a complication occurs, especially intraoperative complication, that can have long-term consequences for the outcome of the operation, and also has a major effect on quality of life.
Thank you so much, Justin. I think I'll have to leave a sticky post-it note on Rochelle's screen. We need to get you back. There's been the board has lit up. So many queries, so many testimonies. It's been wonderful to have you in and getting first-hand report there from the operating theatre.
Thank you very much, David.
My pleasure. Justin Hunt, orthopaedic surgeon at Epworth, answering your questions. Coming up very shortly, we'll be talking about the difficulties of mothering.